Welcome to Hospital Rounds. Today we are working through acute diarrhea. By definition, that means diarrhea lasting less than 4 weeks. It is one of the most common reasons a patient shows up in clinic or in the emergency department. And it is a topic where a good framework beats memorizing a long list of organisms. We will follow one patient from the front door to the discharge plan. Along the way, we will build the 2 big categories of infectious diarrhea, the mechanisms behind them, the organisms in each, the workup, and the treatment decisions that actually change outcomes. One housekeeping note: Clostridioides difficile and chronic diarrhea each earn their own lecture, so we set both aside today. Let us meet the patient. Here is our patient. Marcus is a 38-year-old man with no significant past medical history. He comes to the emergency department with 4 days of diarrhea. It began as crampy lower abdominal pain with loose stools. By the 3rd day, he was going 8 to 10 times a day. This morning, he saw streaks of blood. He feels feverish and lightheaded when he stands up. Before you open a single order set, stop and ask the question that drives everything else. Is this a small bowel problem or a colon problem? Hold on to that question. We come back to it several times today. Notice one more thing. He is a healthy adult with no chronic disease and no medications. So whatever this is, started 4 days ago, and it is acute by definition. Here is where we are going. First, define acute diarrhea and separate it from persistent and chronic disease. Second, build the non-inflammatory versus inflammatory framework and recognize each one at the bedside. Third, understand the mechanisms, how a toxin drives secretion and how invasion drives inflammation. Fourth, match the classic organisms to their exposure history. Fifth, decide who actually needs stool studies. Sixth, recognize the warning signs that change your plan. And seventh, treat correctly, including the situations where antibiotics help and the one situation where they cause real harm. Keep one thread running through all of it. Almost every decision in this topic comes back to which side of the split your patient is on. Let us take the history properly. The diarrhea started 4 days ago. At first, it was watery. Over the last 2 days, the volume per stool has dropped, but the frequency has climbed. He now describes urgency and tenesmus. That is the painful feeling of needing to pass stool when the rectum is already empty. He has cramping across the lower abdomen, worse on the left. He has had subjective fevers and chills since day 2. He has had nausea but almost no vomiting. And this morning there was visible blood mixed into the stool. Notice how that story already points us toward the colon. And notice one negative. He is not vomiting much. Prominent vomiting would have pulled us in the other direction entirely. Now the exposure history. And this is where the diagnosis usually lives. Marcus has no chronic medical problems and takes no medications. He has had no antibiotics and no hospital stay in the last 3 months. That matters. It makes Clostridioides difficile far less likely. He has not traveled outside the country. He has no known immunocompromise. 5 days ago, he was at a backyard cookout. The chicken came off the grill pink in the middle. A housemaid ate the same chicken and now has diarrhea too. A shared food exposure with a second sick person is a powerful clue. Notice what is absent too. No travel, no antibiotics, no immunosuppression. Negatives narrow this differential just as hard as positives do. On exam, he looks unwell. Temperature is 38.7 degrees Celsius. Heart rate is 112. Blood pressure is 104/62 lying down, and it drops when he sits up. His mucous membranes are dry and his axillae are dry. Capillary refill is 3 seconds. The abdomen is soft with diffuse tenderness, worst in the left lower quadrant. There is no rebound and no guarding. Bowel sounds are hyperactive. There is no rash. Rectal exam shows brown stool with streaks of blood. So we have fever, volume depletion, and blood. One more reassuring finding. The abdomen is soft with no peritoneal signs. That argues against perforation and against an acute surgical abdomen. Let us define our terms. Diarrhea is 3 or more loose or watery stools in a day, or a clear drop in stool consistency with more frequent stools than that patient's baseline. Duration is what separates the categories. Acute diarrhea lasts less than 4 weeks. Within that window, most clinicians split further. Roughly 2 weeks or less is acute, and 2 to 4 weeks is called persistent. Anything beyond 4 weeks is chronic diarrhea, a completely different differential, and a separate lecture. Marcus is on day 4. So we are squarely in acute territory. Why does that line matter? Because past 4 weeks the differential shifts toward malabsorption, inflammatory bowel disease, and secretory causes. Why build a framework at all? Because most acute diarrhea is infectious and most of it is self-limited. Norovirus alone accounts for about 50% of all diarrhea. Toxigenic Escherichia coli accounts for more than half of travelers' diarrhea. If you test everyone, you will drown in results you cannot interpret. If you treat everyone, you will cause harm. So the framework does two jobs. It tells you which patients need stool studies, and it tells you which patients need antibiotics. Everything else is hydration and time. Let us build it. Here is the practical framing. In an otherwise healthy adult with watery diarrhea and no fever, the right answer is usually fluids and time. This is the single most useful slide in the video. On the left, non-inflammatory diarrhea. The problem is predominantly disruption of small intestine absorption and secretion. Stools are voluminous and watery. Nausea and vomiting are common. And fecal white blood cells and fecal occult blood are negative. On the right, inflammatory diarrhea. The problem is predominantly colonic invasion. Stool volume is small. The patient has left lower quadrant cramps, tenesmus, and fever. And fecal white cells or fecal occult blood are typically positive. Every organism we discuss lives on one side of this line. One caution: this split is a strong guide and not an absolute law. A few organisms straddle the line, so treat it as your starting point. Before disease, normal physiology. About 9 liters of fluid enter the small intestine every day. Only about 2 liters of that is what you drink. The other 7 liters is saliva, gastric juice, bile, pancreatic fluid, and intestinal secretion. The small bowel reabsorbs roughly 8 of those 9 liters. The colon takes back most of the rest, and only about 100 to 200 milliliters leaves in the stool. The colon also holds reserve capacity. It can absorb several extra liters a day if it has to. Diarrhea happens when that balance tips. 2 consequences follow. A small bowel process can overwhelm the colon and produce liters of stool, and a colonic process produces small volumes even when the patient goes 20 times a day. Here is the non-inflammatory mechanism. Follow the arrows. An enterotoxin binds the surface of the small bowel enterocyte. Inside the cell it switches on adenylate cyclase. Cyclic adenosine monophosphate climbs. That opens the chloride channel on the luminal surface. Chloride pours into the lumen. Sodium and water follow it passively. The result is a large volume of watery stool. Now notice what did not happen. The villi were never destroyed. There is no invasion and no ulcer, so there is no blood and no pus. That is exactly why fecal white cells are negative on this side of the split. Hold on to this mechanism. It is also the reason oral rehydration works, and we come back to that when we treat. Preformed toxin illness is its own category. The toxin is already made in the food before the patient ever eats it. So the bacteria do not have to grow inside the gut first. That is why symptoms arrive fast, often within 1 to 6 hours for staphylococcal toxin. And it is why the whole illness is over in less than 24 hours. Vomiting usually dominates. The classic triad is Staphylococcus aureus from meats and dairy, Bacillus cereus from fried rice, and Clostridium perfringens from rewarmed meats. A short, sharp illness after a shared meal is preformed toxin, until proven otherwise. Contrast that with an organism that has to colonize and multiply in the gut first. Those illnesses take a day or more to declare themselves. Now cross to the inflammatory side. Here the organism invades the colonic mucosa. The epithelium is breached. Cytokines are released. Neutrophils flood into the mucosa. The surface ulcerates. Follow that downstream. An ulcerated colon cannot hold much stool, so the volume per stool is small. The inflamed rectum generates tenesmus and urgency. Blood and pus leak into the lumen. Those neutrophils are exactly what a fecal white blood cell test detects, and the calprotectin they release is what a fecal calprotectin measures. The mechanism explains the entire bedside picture. And this is why these patients look sicker. The fever and the high white count come from the inflammatory response, not from the fluid loss. One inflammatory organism deserves its own mechanism slide. Shiga toxin producing Escherichia coli. The organism attaches to colonic epithelium and releases Shiga toxin. The toxin is absorbed into the bloodstream. It binds a receptor on glomerular endothelial cells. The endothelium is injured. Platelets are consumed and red cells are sheared as they pass through damaged small vessels. That produces hemolytic uremic syndrome, the triad of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. It happens most often in children. Remember this pathway. It changes a treatment decision later. Watch for it in the week after the diarrhea starts. A falling platelet count with a rising creatinine. Let us lock in the non-inflammatory picture before we name organisms. The lesion is in the small intestine. Absorption and secretion are disrupted, but the lining stays intact. So the stools are voluminous and watery. Nausea and vomiting are common and often prominent. Fever is usually absent or low grade. Cramping is periumbilical rather than low in the abdomen. And both stool tests are negative. Fecal white blood cells and fecal occult blood. Here is the practical point. This is the group that almost never needs a stool culture and almost never needs antibiotics. One exception to keep honest. A non-inflammatory illness can still be lethal. Cholera kills through pure volume loss. Here is the preformed toxin group. These are the classic food poisoning syndromes. Staphylococcus aureus toxin comes from meats and dairy. Think a cream-filled pastry or a mayonnaise salad left out. Bacillus cereus is the fried rice organism. Rice left at room temperature and then flash fried. Clostridium perfringens comes from rewarmed meats. A large batch of gravy or stew cooled slowly and reheated. The unifying feature is the clock. The entire illness lasts less than 24 hours. No cultures, no antibiotics, just fluids and reassurance. One discriminator to hold on to: incubation time. Preformed toxin acts in hours, not days. The viruses are the most common cause of acute diarrhea overall. Rotavirus spreads person to person and classically tears through a daycare. It lasts 4 to 8 days. Norovirus is the heavyweight. It accounts for about 50% of all diarrhea. It causes winter outbreaks on cruise ships, in dormitories, and in nursing homes. It spreads person to person and through contaminated food and water. Crucially, there is no lasting immunity, so the same person can catch it again and again. It lasts 1 to 3 days, and vomiting is prominent. One practical point on outbreak control. Norovirus is managed with hand hygiene and isolation. And soap and water beats alcohol gel. 2 bacteria live on the non-inflammatory side. Toxigenic Escherichia coli is the single biggest cause of travelers' diarrhea, more than 50% of cases. It makes a cholera-like toxin, and the illness runs less than 7 days. Vibrio cholerae is the extreme version of the same mechanism. Contaminated water and shellfish are the exposures. The stool is described as rice water, a pale cloudy fluid with flecks of mucus and almost no odor. The danger in cholera is not the organism. It is the speed of the volume loss. A patient can lose more than a liter an hour. Both are managed with aggressive rehydration first. Antibiotics shorten travelers' diarrhea but are not required for mild disease. The non-inflammatory parasites. Giardia comes from streams and outdoor sports, from travel, and from outbreaks. Bloating is the giveaway. It starts profuse and watery and can turn chronic, greasy, and foul-smelling. Cryptosporidium lives in soil and causes waterborne outbreaks. It is usually self-limited, but becomes a chronic infection in the immunosuppressed patient. Abdominal pain occurs in about 80%, and fever in about 40%. Cyclospora comes from contaminated produce and international travel, classically Latin America. One warning: all 3 can leave malabsorption for months after treatment. The common thread is water and travel, so ask about camping, about wells and streams, and about imported produce. Now the inflammatory picture. The lesion is in the colon, and the mechanism is invasion. Stool volume is small because the colon cannot hold much. The patient has left lower quadrant cramping, tenesmus, and fever. And fecal white blood cells, or fecal occult blood, are typically positive. Compare that with what we just built. Non-inflammatory means big volume and negative stool tests. Inflammatory means small volume and positive stool tests. This is the group where a stool culture is worth sending. And it is the group where antibiotics sometimes belong. The split is not academic. It is the whole decision tree. One caveat. The fecal white blood cell test is neither perfectly sensitive nor perfectly specific, so read it alongside the story. 3 headline bacteria. Campylobacter comes from undercooked poultry and unpasteurized milk, and it is carried by puppies and kittens. It often opens with a prodrome of abdominal pain that mimics appendicitis, so-called pseudoappendicitis. It can be complicated by Guillain-Barré syndrome and by reactive arthritis. Non-typhoidal salmonella comes from eggs, poultry, milk, and pet hamsters. Bacteremia occurs in 5 to 10%, and 10 to 33% of bacteremic patients over age 50 may develop aortitis. Shigella is abrupt, no vomiting, gross blood and pus, and a strikingly high white count. One practical note: Campylobacter and Salmonella are the 2 bacterial causes you will meet most often on a general medicine service. Next group. Shiga toxin-producing Escherichia coli includes O157H7 and the invasive or hemorrhagic non-O157 strains. Exposures are undercooked beef, unpasteurized milk, raw produce, and person-to-person spread. 40% of the non-O157 strains also make Shiga toxin, which can cause hemolytic uremic syndrome, typically in children. Gross blood is the rule. Vibrio parahemolyticus comes from undercooked seafood. Clostridioides difficile follows recent antibiotics or healthcare exposure. Its toxins inflame the colon and cause watery or bloody stool with cramping and leukocytosis. A full lecture covers it. One rule from this row: bloody diarrhea after ground beef means hold antibiotics until you know more. Salmonella typhi is a different animal from its non-typhoidal cousin. The exposure is travel to Asia, Africa, or South America. The picture is systemic toxicity rather than a simple gastroenteritis. Look for relative bradycardia, a fever that climbs while the pulse stays low. Look for the rose spot rash. The bowel often goes quiet with ileus first, then produces the classic pea soup diarrhea. Bacteremia is expected. In the other category, Yersinia comes from undercooked pork and unpasteurized milk, and causes pseudoappendicitis from mesenteric adenitis. Aeromonas, Plesiomonas, and Listeria come from meats and cheeses. Notice that nearly every one of these is still a food exposure. The history remains your single best diagnostic test. 2 more to close out the inflammatory table. Entamoeba histolytica comes from contaminated food and water and from travel. It is rare in the United States. The feature that must not be missed is that it can seed the liver and cause a liver abscess. So a returning traveler with bloody diarrhea and right upper quadrant pain needs imaging. Cytomegalovirus is a disease of the immunosuppressed patient. Transplant recipients. Advanced human immunodeficiency virus. High-dose steroids. The diagnosis is made on colonic biopsy using shell vial culture. You will not find it with a stool culture. The lesson is to match the test to the organism you suspect. A routine stool culture will miss both of these. Back to Marcus. Let us use the framework. His stool volume per episode is small. He has left lower quadrant cramps. He has tenesmus. He has fever. And he has visible blood. Every one of those findings sits on the inflammatory side of the split. Now add the exposure. Undercooked poultry at a cookout 5 days ago, with a second sick person who ate the same chicken. That combination points hard at Campylobacter. So we know 2 things. This patient does need stool studies. And this patient may need antibiotics. Let us build the workup properly. Notice how fast the framework did the work. 5 bedside findings and 1 exposure question. No advanced testing yet. Before we commit to infection, run the non-infectious differential. Hyperthyroidism speeds transit. Adrenal insufficiency brings diarrhea with hypotension and hyponatremia. Medications are a huge bucket. Antibiotics, antacids, and immune checkpoint inhibitors, which cause a true immune-mediated colitis. Appendicitis and diverticulitis can both present with diarrhea rather than classic pain. Radiation to the pelvis causes proctitis. And the first presentation of inflammatory bowel disease or celiac disease can look exactly like an infection. If cultures are negative and the patient is not improving, reopen this list. 1 habit worth building. Always ask what medication started in the last 2 months. 7 questions do most of the work. How many stools a day? Is there blood? Where is the pain? How long has it been going on? Where have you traveled? What did you eat? And have you had antibiotics recently? Then ask whether the patient is immunocompromised. The duration answer is the one residents underuse. Viral and bacterial causes generally run about a week, with Clostridioides difficile as the exception. If the diarrhea has run longer than a week, start thinking parasitic. That single question decides whether you order stool ova and parasites. 1 more question is worth asking. Has anyone else who ate the same meal become ill? A shared source shortens the list very quickly. The exam has 1 main job: quantify volume depletion. Look at the vital signs, including orthostatics. Ask about urine output. Feel the axillae, they should be moist. Check skin turgor. And assess mental status. A confused elderly patient with diarrhea is volume depleted until proven otherwise. Then look for the other 4. Fever, abdominal tenderness, ileus, and rash. Ileus matters because it can be the first sign of toxic megacolon. And rash points you toward typhoid with its rose spots. Marcus is tachycardic, orthostatic, and dry, so he needs fluid before anything else. 1 bedside rule to carry. A resting tachycardia together with a positive orthostatic change means significant losses. Now the laboratory. Start with fecal calprotectin. It is released by neutrophils and it separates inflammatory from non-inflammatory disease. Send a stool culture when the picture is inflammatory. Send blood cultures. Remember, non-typhoidal Salmonella is bacteremic in 5 to 10% of cases. Check electrolytes. Diarrhea drives hypokalemia and a non-anion gap metabolic acidosis from bicarbonate loss. And test for Clostridioides difficile, only if there has been recent hospitalization or recent antibiotics. Marcus has had neither, so we are not sending that test today. One caution on stool culture: the yield is low in watery non-inflammatory disease, so reserve it for the inflammatory picture. Stool ova and parasites is the test residents order reflexively and usually wrongly. 6 situations justify it. First, the diarrhea has lasted more than 10 days. Second, travel to an endemic area. Third, exposure to unpurified water, a stream, a well, a lake. Fourth, a community outbreak. Fifth, daycare exposure. And sixth, a patient who is positive for human immunodeficiency virus, or a man who has sex with men. If none of those apply, the test will not help you. Marcus is on day 4 with no travel, so we skip it. And remember why this matters. A parasitic cause needs a different drug, metronidazole or nitazoxanide, rather than azithromycin. 2 more tiers. Stool antigen tests by enzyme-linked immunosorbent assay can find viruses, Cryptosporidium and Giardia. Serology is how you chase Entamoeba histolytica. Then there is the multiplex polymerase chain reaction panel. The BioFire gastrointestinal panel tests for 22 organisms at once and turns around fast. But use it thoughtfully. It has a high positive rate, and a positive result does not tell you whether the organism is truly causing disease or is simply colonizing the gut. The reasonable place to reach for it is the immunocompromised patient. One workflow point: a fast panel result does not replace the clinical decision about whether to treat. These are the warning signs, and they are the hinge of the whole management algorithm. Fever, severe abdominal pain, blood or pus in the stool, more than 6 stools a day, severe dehydration, immunosuppression, advanced age, duration longer than 7 days, and diarrhea that began in the hospital. If none of these are present, you are almost always looking at supportive care and nothing more. If any of them are present, you escalate. Stool studies, imaging if indicated, and a real conversation about antibiotics. Count Marcus: fever, blood, more than 6 stools a day, and dehydration. So Marcus moves on to the escalated pathway, and that is exactly where we go next. Imaging and endoscopy are not routine. Consider them only when warning signs are present. Get a computed tomography scan or a plain abdominal film if you are worried about toxic megacolon. The clues are abdominal distension, a quiet abdomen with ileus, fever, and a rising white count in a patient who looks toxic. Move to sigmoidoscopy or colonoscopy in 2 situations: the immunosuppressed patient, where you may be looking for cytomegalovirus on biopsy, and the patient whose cultures are negative but who is not getting better. In that second group, you may be uncovering inflammatory bowel disease. And one safety point: when you suspect toxic megacolon, imaging comes before any endoscopy. Here is what came back on Marcus. The white blood cell count is 14,200 with a left shift. Sodium is 132, potassium is 3.1, bicarbonate is 18, and creatinine is 1.6, up from a baseline of 0.9. So he has acute kidney injury from volume loss, plus hypokalemia and a non-anion gap acidosis from losing bicarbonate in the stool. Fecal calprotectin is markedly elevated, confirming inflammatory disease. Stool culture and blood cultures are sent. Now let us treat him. One teaching point on that acidosis: bicarbonate lost in stool gives a normal anion gap, so if the gap is wide, go looking for a second process. Start with the easy branch. If there are no warning signs and the patient is drinking normally, treatment is supportive. Hydrate. Loperamide is acceptable in that setting, and bismuth subsalicylate is a reasonable alternative. What you avoid is anticholinergic agents. 2 cautions on loperamide. Do not give it to a patient with fever and bloody stools. Slowing the gut in an invasive infection risks prolonging the illness and can contribute to toxic megacolon. And if you do use an antimotility drug in an inflammatory picture, give it only alongside effective antibiotic therapy. One counseling point: bismuth subsalicylate can turn the stool and the tongue black. Tell the patient before they panic. Rehydration is the treatment that actually saves lives. For moderate dehydration, give 50 to 200 milliliters per kilogram per day of an oral rehydration solution. A commercial sports drink works in a pinch for an otherwise healthy adult. Here is the physiology behind it. The toxin blocks sodium absorption through one pathway, But the glucose-coupled sodium transporter keeps working, so a solution containing both sodium and glucose still pulls water back across the gut wall. That is why oral rehydration works even in cholera. For severe dehydration, go straight to intravenous fluids and follow the response rather than a fixed volume. Urine output and the creatinine tell you whether you are winning. If you suspect traveler's diarrhea, azithromycin 1 gram as a single dose is the preferred choice. The reason is fluoroquinolone resistance, which is now widespread in Asia. Rifaximin and rifamycin are alternatives. They stay in the gut lumen and are a reasonable choice for watery traveler's diarrhea without fever or blood. If instead you suspect a protozoal cause, a traveler with more than a week of symptoms and bloating, treat with metronidazole or nitazoxanide. Match the drug to the mechanism you suspect, not to the loudest symptom. Prevention matters more than treatment here. Bottled water, hot cooked food, and hand hygiene. And note that rifaximin is not the choice when there is fever or blood. Now the harder branch. For inflammatory diarrhea that is not Clostridioides difficile, empiric antibiotics are reasonable when the disease is severe. Severe means any of these: fever, more than 6 bowel movements a day, hospitalization, bloody or mucoid stools, or a high-risk patient, meaning older than 70 years or immunosuppressed. The regimen is azithromycin, 1 gram as a single dose, preferred when there is fever or dysentery. The alternative is a fluoroquinolone for 3 to 5 days, but resistance is rising, and that is pushing azithromycin to the front. One reminder, this branch excludes Clostridioides difficile. That pathway is different and is covered separately. And now the exception that can hurt someone. Avoid antibiotics if you suspect Escherichia coli 0157H7. The clues are the exposure history: undercooked ground beef, unpasteurized milk, raw produce, and gross blood in the stool. Antibiotics in that setting may increase the risk of hemolytic uremic syndrome. Go back to the mechanism slide. Antibiotic stress on the organism can drive more Shiga toxin release, and it is the toxin that injures the kidney. So when the story is bloody diarrhea after a hamburger, you hydrate, you send cultures, and you wait, and follow the labs for about a week. A falling platelet count with a rising creatinine is the signal you cannot miss. 5 pitfalls to carry with you. First, ordering stool ova and parasites on everyone. It is only useful with the right trigger. Second, giving loperamide to a patient with fever and bloody stools. Third, reaching for antibiotics when Shiga toxin-producing Escherichia coli is possible. Fourth, anchoring on infection and missing the mimics. Immune checkpoint inhibitor colitis and a first flare of inflammatory bowel disease both live here. And fifth, treating a positive multiplex panel instead of treating the patient. A positive result can mean colonization. The clinical picture still decides. Every one of those 5 is a decision you make in the first hour of caring for the patient. Here is the assessment and plan. Marcus is a 38-year-old man with acute inflammatory infectious diarrhea, most likely Campylobacter, given the undercooked poultry and a second sick contact, complicated by hypovolemic acute kidney injury and hypokalemia. The plan: intravenous fluids with potassium repletion, stool culture and blood cultures already sent. He meets severity criteria: fever, more than 6 stools a day, and bloody stools. So we start azithromycin 1 gram as a single dose. We hold loperamide because he is febrile and bleeding, and we reassess kidney function in the morning, and we counsel him on food handling before discharge. Undercooked poultry is a preventable exposure. Let us close the loop. First, acute means less than 4 weeks, and the non-inflammatory versus inflammatory split organizes everything. Second, non-inflammatory means small bowel, large volume, negative stool tests, and almost never antibiotics. Third, inflammatory means colon, small volume, fever, tenesmus, and positive stool tests. Fourth, the exposure history usually names the organism. Fifth, the warning signs decide who gets tested and who gets treated. And sixth, the one-time antibiotics do harm is suspected Shiga toxin, producing Escherichia coli, where they may raise the risk of hemolytic uremic syndrome. Carry the split with you. It answers almost every question this topic can ask at the bedside. These are the primary sources behind this teaching. The American College of Gastroenterology Clinical Guideline on Acute Diarrheal Infections in Adults from 2016. The Infectious Diseases Society of America Practice Guidelines for Infectious Diarrhea from 2017, along with major review articles in the New England Journal of Medicine, the Journal of the American Medical Association, and The Lancet. Take these back to your own reading. Thanks for rounding with us today. One reminder as you read: always check for a newer version of a guideline before you apply it to a patient.